Welcome everybody to another Wednesday session of the FRCS Mentors. Today I am very pleased to be able to present Mr. Paul Harnett of King's College Hospital in London, as well as the Cleveland Clinic. He's going to talk to us about pelvic and acetabular trauma, focusing on the FRCS as always. Thank you very much, Mr. Harnett.
Okay, thank you very much. We also, I'm at King's College Hospital. I run the trauma, I'm the lead of the trauma. Consultant for about 7 years. I have 500 operative pelvis cases we just hit the 500 mark last month on our database. About half of those are acetabular and half of them are pelvis ring. Probably half of them are young patients, half of them are geriatric. So it's a full mixed bag, and so we're operating on almost 100 cases per year now. We also run one of our own FRCS courses, and this tends to be the theme of the. So what I've sort of split this into and into pelvis. So there's pelvis rings, and then particularly for the FRCS. You're going to be dealt with an acute emergency situation. I have to say it's very higher level stuff to start to talk about any detail of operative approaches and things. If you start to get that far, you're doing very well. And again, as with the technique of FRCS vivas, is not to suddenly jump into the minutia detail of a stopper approach, because then you've skipped out the part of your ABCs and resuscitation and nerve assessment. So we'll talk about that so the patient is adequately prepared for the surgery, because as you know, the FRCS is designed to be you as a day one consultant, likely to be at a district general hospital, and that's possibly dealing with the initial treatment, not necessarily, and have an idea and an understanding of the fixation and the principles, but not necessarily the intricate details. So if you suddenly dive too deep, then the rest of the viva will be spent on that fine detail. And so your FRCS technique is to swim in the shallow end and only dip into the deep end if you're really prepared and have some control about that. So without further ado, let's move on. So we're going to start off with acetabular fractures. I have to say, when I was a very young, not the FRCS level, but like a year one registrar, I remember thinking I hardly even knew the difference between a pelvis and an acetabular fracture. And make people go, oh, it's pelvis fracture, pelvis fracture. Like, well, no, it's an acetabular fracture. And it's like the only difference between a tibial plateau and a fracture and a pilon fracture. They are completely other ends of the spectrum. Occasionally you can have both, just like you could have a plateau and a pilon fracture, both ends of the tibia. There's some generic, and you don't need to know about this, we'll skip through this. And so when we talk about the femoral head, and obviously it's impacting into the acetabulum, sometimes that can be from just from standing height, they have poor osteoporotic bone, and sometimes obviously it's high velocity injuries. And occasionally acetabular fractures do cause significant damage to vessels. You can have an obturator artery injury. Very rarely you can have a superior gluteal. And then particularly when the head dislocates out the back, it can damage the sciatic nerve. We get all very excited about foot drops and fractured dislocated hips. Very classic question is, what are the 6 lines seen on a standard AP pelvis? And I'll quickly skim by this, but obviously there's this iliopectineal line, which is the brim of the acetabulum, and that represents the anterior wall. We can see this done. This is a normal AP pelvis. And the problem about a normal AP pelvis, as we'll allude to on other views, is actually an obliquogram of every part of the acetabulum, and it's an obliquogram of the pelvis and the pelvis ring. But from these obliquograms, there are still some standard things that we look at. And so this iliopectineal line represents our anterior column, and I'll come on to that. We're obviously looking at the dome of the acetabulum. The teardrop is this strange configuration you can't actually see on a normal pelvis, but it's a configuration of the bones that as a viewing point. And this ilioischial line representing the posterior column. And then you basically, with this anterior wall and posterior wall, you kind of squint and pretend you can kind of see it. You'd be lucky if you could. Occasionally, you can see a subtle posterior wall. And to be honest, most trauma patients are going straight to CT scanners. And then, in fact, we don't even get Jude views and things because and then with a 3D CT scan, you then make a simulated X-ray, and then you could rotate it. So you do a simulated Jude views. So moving on, classic textbook. I have to say, when I was learning my acetabular fixation, I never understood these pictures. Were very foreign to me because you never see an X-ray in this picture. You never see a pelvis in this view, and yet someone's drawn all these funny lines. And so it's really difficult to try to understand these. This is a 2D, not even 2D drawings of the acetabulum. Yet this Jude Letournel from their series, who are sort of the godfathers of acetabular surgery throughout the 60s, 70s, and 80s, and their presentation of 500 operative cases, all based on young patients. And so you quite often find that the geriatric acetabular fractures, and we'll come on to this, the quadrilateral plate is blown out, and yet the posterior column's intact and the anterior column's intact, and it's poorly classified. But when we are thinking and speaking to each other, we classify things according. And my entire database is all based on the Jude Letournel classification, and there are some prognostic indicators. One of the big mistakes that people are saying is they think that there's, for example, this transverse fracture, anterior column, and there's a fracture of the posterior column. Therefore, it's a both column fracture. And so people can call this associated both column fracture in ABC. But yet, a transverse fracture is not an ABC. And so it's a very common mistake to consider both columns that are involved with the fracture to call it an ABC. And then this has prognostic indicators and approach problems as well. And so then the real distinction part of a ABC fracture is that no part, so there's neither this posterior part nor this anterior part, is attached to the posterior, the constant fragment. For all articular cartilage fracture treatment throughout the whole body, we're always trying to build things back onto the constant fragment. And so when there is no element of articular cartilage attached to the constant fragment, therefore it's an ABC. And in simple ways, when it's really, really smashed up, if your best bet is to call that an ABC. So here we see this anterior column posterior hemitransverse, where we see there's an anterior column, and I've got some better pictures of this, but you see that the anterior column is fractured, the posterior column is fractured, but yet here we see there's still a little bit element that's remained to the constant fragment, and that has prognostic indicators and how we fix it. I'll just run through this quickly. So anterior columns, we don't see that very often. Anterior wall, it's not very exciting. We don't operate on that very often. An isolated posterior column, it's pretty unusual, to be honest. It's usually a posterior wall. If it's just a posterior column, that can be fixed percutaneously. I'll go on a little bit about that. Posterior wall fractures, that's our most common. That's the highest. We're fixing those once a week. With maybe not quite once a week, but certainly 2 or 3 times a month, with a hip fracture dislocation that dislocates the hip, and it takes a little fragment with it, and that's unstable. And we talk about how we describe that as stable and unstable. Most of them are all unstable. Some people can dislocate without a fracture, and that becomes a little bit of a conundrum. I can talk lots and lots about posterior wall fractures. These transverse fractures have a high velocity, and you'll often see that the head is medialized. There's old school, there's central dislocation of the femoral head, and that's often with a transverse type fracture. And I'll talk about your approaches about before. T-type is quite rare in that series. It's only about 5%, but it's really tricky because you can see you can fix it from the, we'll talk about how you do the approaches when you fix it from the front and fix it from the back. But here often needs a dual approach. This transverse posterior wall, anything that involves the posterior wall has to be fixed with Cocker-Langenbeck approach. We'll talk about that as we go along. And then there's transverse elements, so that when you're doing the Cocker-Langenbeck approach, you can't actually access the anterior column. Any anterior column and quadrilateral plate needs to be fixed through an intrapelvis approach. Posterior column, posterior wall, they can fix that through a Cocker-Langenbeck approach, all fairly straightforward. And this is the most common, but I think we're seeing this more and more now because of our geriatric injuries. So we move on. I'm going to give you some 3D examples of this. Just got a pint of Stella. I've just gone home from work. I was operating at 6:30, so I did well to get home on time. So this example is a transverse fracture. So we're seeing a bit more of a 3D image here. So it's going from the front to the back. And here, like I was talking about, you'd see this central medialization. We see this iliopectineal line is particularly disrupted. We're seeing this ischium, which is medialized and disrupted. So some people will say, oh, that's both columns are fractured, but no, that's just a transverse fracture. The CT scan, you'll see the fracture line going from the anterior column to the posterior column. And therefore, this is your transverse element. And here, when you see lines going across on the CT, reading axial CT scans is quite difficult in trying to orientate it. Actually, to be honest, these days, we just click on the 3D recon button and it creates a 3D scan for us. When you're reading x-rays, I teach my fellows, my acetabular pelvis and acetabular, you have to be able to read x-rays because intraoperatively, all you've got is an II. So if you're just always used to looking at CT scans and 3D recons, you can't get that in theaters. Although actually, we've just started doing intraop CT scans and you can then get 3D scans, but that's cutting edge stuff and not applicable to most centers. And on the x-rays in theater, you do still get the Jude views, which we'll talk about, which are the 45-degree oblique views, looking at those both. So we're still on to this, our acetabular fixations. And so and the reason that Jude-Letournel is such a great classification system is because once you classified it correctly, then the treatment algorithm works very well. It's like, oh, it is a transverse posterior wall fracture, therefore I do this approach. Actually, if we go back, those transverse fractures, we debate, can you fix this from the back or for the front? And actually, we now often try to fix a dual approach. So this needs buttressing back, and then the posterior column needs fixing from the Cocker-Langenbeck or percutaneous, to be honest, if you can get it really snug tight. But you can see how this pretty much has to get buttressed back on. And if you're trying to fix that from behind with the Cocker-Langenbeck approach, you're very difficult. You often pinch it at the back and it opens at the front, and you can't access both the front and the back at the same time. Well, you can just about get that posterior column, but the fixation of it is inadequate. And so here, when we see this is a T-type, and so here we see, which is essentially this transverse here, and then there's an extension vertically through the condyloid fossa, and then through this obturator foramen, and sometimes it can exit high and low, so there are variations of this. But you can see how once you could fix this perfectly here, the posterior column, you've got no access to this anterior column fracture, and vice versa. You could fix it all here, but you've got no access here. And so these T-types often require, well, you could pretty much say every time, that they need a dual approach. There are some times where if you thought you could intrapelvic, you could see you could fix that perfectly. You could visualize that and then fire a posterior column screw, which is starting here and finishing here. people will debate whether you can get that a nice compression across that. It's quite, and some people even put in internal posterior column plate, but that's very deep, higher learning stuff. Don't let me, I try not to confuse you. So here we're seeing that both this is transverse and the posterior wall is damaged, quite common. And again, so you have to go through the Cocker-Langenbeck approach to fix here, and then you'd squeeze that down. Now, whether you'd probably you'd be able to get what's called a young bluff. There's only a few particular pelvis instruments that are on the pelvis set, and one's called some people call it the JB. Young is spelled with a J, is very news, and a Fairbluff, which grabs the iliac crest. But the young bluff is where you drill it in here and drill it in here, kind of like a Hinterman, but with K-wires. Some people might have used for foot and ankle type surgery, but here you actually drill it with small fragment screws, and then you can clamp it down here, and sometimes you can get a finger and see it. Some people will even do a surgical dislocation with a Gans osteotomy to visualize that, and getting that fixation is difficult, and whether it needs an anterior approach. But again, for your FRCS level, you want to don't get bogged down with the classification system. You can see there's if you just said there's an acetabular fracture, there is disruption of the iliopectineal. Just describe what you see. There is disruption of the iliopectineal line. There is a posterior wall element to this. This is grossly unstable. I'd have to make sure that the vessels were not damaged and that the nerve is intact. And that's it. Don't go deeper than that. If you go, oh, there's a Judelet-Fresnel, and they go, oh, really? Tell us all about the Judelet-Fresnel classifications. So once you mention that, then you'd be obliged to describe all 10. But if you simply describe what you see, you say, oh, I see that there's a disruption of this, and then that's it. And then let them maybe take you to, they say, oh, do you know classifications? And you say, yes, it is the Judelet-Fresnel. Which you could, and again, you could stay superficial. Say, oh, there are 5 simple fractures and 5 associated fractures. Stop. That's it. And like, okay, so you know that there's a general principle. The general principles are that there are simple fractures and more complex fractures. You don't necessarily have to remember all 10. Here we go, going a little bit deeper. So here, this is our classical anterior column fracture, and then it's a half a transverse. Mi, it's French, mi transverse. You have to say it with an outrageous French accent while you say that. And these are actually the ones you see geriatric fractures, which I'll show you. They fall over, they've got osteoporotic bone, the quadrilateral plate has this tiny little blowout to it. The quadrilateral plate is poorly described from all this classification system. Essentially, you can see the quadrilateral plate is the posterior column. So when the quadrilateral plate is blown out, by and large, the posterior column is part of that, because we know that they were initially describing this large anterior column, this large posterior column. It's just strong bones that are piercing the acetabulum, which is dome shaped, which is very difficult for us orthopedic surgeons. We're normally dealing with straight bone, but now we're dealing with this spherical bone. But the way we get around that is that we have straight anterior column and posterior column. We can fix that with straight screws and straight plates. Here's another example of this posterior column fracture and a posterior wall. And so here we see this posterior wall fracture, and then here on the Judet. So this is an example of our. And you probably should be expected to notice that your Judet views, which is 45 degrees both ways. So 45 degrees, let's call it, and the 45 degrees on this side is your iliac oblique. So one's obliques of both. So it's an iliac oblique looking at the posterior column, and then your obturator oblique. So this is of the left, and here on the right, this is an obturator oblique. And then you can almost, I call it this alpoo. So the posterior wall is seen on the obturator oblique. And an obturator oblique view is essentially an AP of the obturator foramen at 45 degrees, and then you'll see the posterior wall. It's not quite coming out on that x-ray. And then you realize that everything follows on from that. If it's posterior wall is on the obturator oblique, then that must be anterior column, posterior wall, anterior column, and then posterior column and anterior wall. Anterior wall fractures are unusual. And then here, smashed to shit. Anything that's all smashed and you can't see anything, think about an ABC fracture. There's no part of articular cartilage which is attached to the constant fragment. All right, so here we're seeing these obturator oblique views. Again, old fashioned, they used to put triangles and things. In reality, we're doing these simulated with the CT scan. But I see them in post-op in clinic. In clinic when I see them at 6 weeks, I don't get another CT scan. I do get post-op CT scans on all my patients. And so here, this obturator oblique, I'm seeing an AP of the obturator foramen, which shows me my posterior wall and my anterior column. And here I'm seeing the posterior column on my iliac oblique and the anterior wall. And you do need to know these because, like I say, intraoperatively, you need to be able to see all of these. So if you can't read plain AP pelvis X-rays or obturator views, then you can't operate on acetabular fractures in theatre. All right, so there's some more examples of that. So now you've classified your fracture. Patient's stable. You've quite a common question at FRCS is you've got a hip that's fracture dislocated. What should you do? And like a shoulder, you should try to reduce it. And they go, oh, but you're not the acetabular unit. Well, I thought, you know, like a shoulder, you try to reduce a shoulder you're not necessarily a surgeon that could do an open approach to a shoulder, although most of us could. You don't have, it's very, very, very unusual for an acetabular fracture to be irreducible. And yes, there is pressure on the sciatic nerve. As you can see, the sciatic nerve coming out here of the sciatic notch. Maybe I'll go back a bit. Pictures. If it's dislocated out the back here, damaging that sciatic nerve. So you'll reduce that fracture, and traction. It needs about 10%. So you're looking at, you know, at least 5 kilos. It doesn't have to be skeletal traction. It can be skin traction to prevent that hip from dislocating back again. So you've pulled it, you've reduced it, but that needs to have traction. We've had, I started my FRCS course, or my pelvis course specifically, we had several cases where they reduced it and left it and then transferred. And by the time they arrived to us with no traction, the hip had dislocated again. It can be grossly unstable. And very unusually, that it's so damaged that even traction doesn't keep it very well reduced. But traction is important, and even traction to take tension off those fragile articular cartilage, and then particularly the sciatic nerve, which runs right behind the acetabulum. So that's why we worry about the sciatic nerve getting damaged. And it can be damaged, or it's damaged about 10% of the time with a dislocation, and then you pull the hip jack. But what we want to know is, was it damaged the whole time, which it often is, or can it be damaged so it was working, then you've done the closed reduction, and then the sciatic nerve isn't working? To be honest, I've never seen that, but one of my colleagues, he saw that, so that when we do the open, and then that's a surgical emergency. You've managed somehow the nerve has been trapped inside the joint after the reduction, and then, you know, it's a huge skipping rope sized nerve that's inside the joint. So you got to get to that within 6 hours. But we need to know the status of the nerve right from the get-go. And often it is damaged, and there's not much treatment except for wait about a year. Sometimes they do get scar tissue around the nerve, and there are peripheral nerve injury. Colleagues can help decompress that at a later stage. When we talk about some surgical approaches, really the old school is this ilioinguinal. We don't do this. It's very unusual to need to do this again. We used to do the big ilioinguinal, which would be from the iliac crest all the way through, isolate the vessels, and get down and clamp that. Now, 98% of the time, we'll be doing and I'll explain to you what this is on my next slide. the stopper approach. And then sometimes what we'll do is we'll start off with the stopper approach, and then we do a lateral window, which is the proximal part of the ilioinguinal. We'll come underneath, so we'll get to see all of this, but we just leave, and then we'll do our stopper, and then we leave this big gap here, so we don't dissect out all of this, and we stay miles away from the vessels. And we can push the vessels laterally, we can push the vessels medially. It's only occasionally where the fracture line is right here, right under near the vessels, and that's where our reduction and that's where our fixation needs to go, that we'll extend and connect the two and isolate the vessels. But often with cob and elevator underneath the iliopectineal fascia, which is this sort of, it's almost like a fascia, it is a fascia, that it's poorly described, so that we can push we get a cob under here and we push the vessels out of the way. So here's our stopper approach. We're standing on the other side of it. And the reason we're doing the stopper approach is that we medialize, so we can get plates on the inner brim. And we can buttress here. We often get a buttress plate right here. And there's even now anatomical plates that we sometimes use, and they don't always fit. And the ability now to buttress this quadrilateral plate. And here is often constant fragment, and here is fractured fragment. So we take down the corona mortis, which is a vessel we see 95% of the time. And so it's connecting the obturator to the external iliac vein, and it runs here, and we ligate that. And then once we've ligated that, we just cob underneath this iliopectineal fascia here, which we cut through with a 15 blade or diathermy. And then you often don't see the vessels at all. You just know that you're underneath, and you're very, very gently, and you can mobilize and push it, all of this. Occasionally, sometimes that in older patients, we will see, we call this big blue or big whale. We're like, oh my God, that's the size of a garden hose. And you could, theoretically, you could slip with a cob and pop through. Something to one of my colleagues since. But we've done literally 250 of these. And so our indications to operate are, sometimes we can do it just through the stopper. It's like a phalansteal incision. Well, it is a phalansteal incision, but so it's very low morbidity, a few hundred mils of blood loss. The buttress this down and then getting it out. So our indications to operate are, because we're doing this week in, week out, to stabilize it, just like we're doing more and more total hip replacements to allow early full weight bearing. And also knowing that anything more than 0.5 millimeters in the acetabulum is prone to post-traumatic arthritis and the ability to put full weight bear. So we're much more aggressive. Good, and then you can see here, sometimes when we do this, the view from the iliac crest, we slide the plate underneath, and you can get through this lateral window. Actually, you often walk around to the other side, and then you can connect the two. And so you're sliding the plate underneath the vessels, but you're connecting both these lateral window and this, but you're just leaving the skin. So you can slide the plate underneath. Well, so we'll move on. We've talked about these disruptions here. We talked about this. So this, we talk about the CT scans, and so we like the dome, which is essentially what we're fixing. So you can see that we need to fix this anterior column back to the posterior column. So that sometimes you need to get a Shannon spin, and if I wanted to put a Shannon spin in here and then internally rotate and clamp it down here, that would be everything's always about the reduction and the exposure to that. And so I know that would be my maneuver, and I know this would be my constant fragment. And when we get our post-op CT scans, or now we're sometimes getting intra-op CT scans, this is what we're really concerned about. This is the dome. This is the articular cartilage. And this we're trying to get to within 1 millimeter. And so here we're seeing this multi-fragmented. This is representing our quadrilateral plate. And we know that this buttress is back onto here. And then this anterior column flips back down to here. And what to do about this posterior wall element. You can also look at the soft tissues. You can see there's lots of hematoma here, disrupting and pushing onto the bladder. So this is this classic picture. So you're like, okay, how do I fix this? And this is the view you're getting from a stopper approach. And this is your anterior column. This is this anterior column and half a transverse. And so the quadrilateral plate here is blown out and the head is sitting in here. And actually there were often on these 3D reconstructions, and this is actually a bit of an old school 3D reconstruction, but you still wouldn't see it because it morphs it. But on the 0.625 CT scans, you'll see a tiny little fracture line here. It's almost always complete. Sometimes it is incomplete, so the posterior column's intact. So then that doesn't really fall into the Judet-Letournel classification system. But this is, and some people say it's trying, that's a great concept, trying to be an ACPH, anterior column and half transverse. Again, you don't have to get bogged down if you've got this and it's like, okay, well, I can see there is a displaced acetabular fracture. It's involving the anterior column and the quadrilateral plate. My basic principles is that this will require operative fixation. This is an unstable fracture that will require, I think, if the patient is fit and stable, would require operative fixation to stabilize that fracture to allow for early mobilization. And then you could go on about whether they need a total hip replacement either that day or the following week or whatever. And there's some other indications that require total hip replacement, such as dome impaction or femoral head damage. And you can see, again, you're like, oh, how do you fix this? You're like, well, basically, I need to put this back to it. So I buttress this down and I buttress this down. And unfortunately, with acetabular surgery is that we just can't put screws on either side of the fracture because those screws would go into the joint. So what we do is we put a few screws here, we can put a few screws here, and the whole plate just acts as a big buttress. Occasionally, we can augment it with a plate here. And again, here, this is our constant fragment, and we just need to buttress it back down. Okay, and then we've talked about the classification system and how it helps treat us. The Cocker-Langenbeck approach is essentially very similar to your posterior wall. Your posterior approach that you've all done probably lots of hip replacements for the posterior approach. And it's a classic FRCS question: is what's the difference between a Cocker-Langenbeck and a posterior wall? Posterior approach. And the key thing here is that you're not taking the capsule down; you're just taking the piriformis and the obturator internus, and you're preserving. And the reason you take that, you always describe and you learn about the approach, is that you take it 1 to 2 centimeters away from the greater trochanter, whereas normally when you're doing that normal posterior approach, you're trying to detach the piriformis as high up into the greater trochanter as you can, and then you come all the way down towards the quadratus femoris. And then often when you're doing the posterior approach, taking the capsule at the same time, and you hit that bleeder sod, it's blue, and that is the circumflex, medial circumflex vessel, and that's what we're preserving, and that is the femoral blood supply to the capsule. So when we do our posterior wall, that's what we stay miles away from that. So we're just taking the piriformis, and we just take the obturator internus, and then we peel back the capsule, trying to preserve the blood supply to the femoral head. Classic FRCS question. We just talked about that stopper approach, and then sometimes you have to do both. And then some classic, what are the complications of an acetabular fracture? There's obviously, in case you can have instability, a post-traumatic arthritis, heterotropic ossification. People used to give it indomethacin. We don't do that quite so much anymore because it doesn't actually work, and it can have some quite a lot of gastric problems and things. And infection can be a problem. And then the nerve and occasionally the vessels. But the sciatic nerve damage is a constant big one. Good. So here's a case that you can see this posterior wall is damaged. We can see this here, and the surgery is simply to push that back down. And so you can only treat that with a Cocker-Langenbeck approach, where not dissimilar to your posterior approach, but we take a cob, and we find that fragment, we pin it back down. Again, you have to buttress it with here and screws through here, and these screws have to go from here and outside the joint. And that's why we get our Judet views, and we look down the barrel of the screw to see it's not intra-articular. Here's sort of an example of it. So again, just basic principles. How would I fix this fracture? Well, I know that this fracture needs to go back to here, and this is constant fragment. So I could buttress that back down, and this is quite difficult to see, but this is an anterior column element to it, and I'd want to fix that. And then through the CT scans, you'd want to see that there's what's going on exactly with the posterior wall. Again, the keen people here, this is a combined pelvis ring injury. That's very severe and unusual. But this would probably also need fixation as well. And then you've got some widened sacroiliac joints. You can actually have a pelvis and an acetabular fracture. You can imagine this massive lateral force and everything breaks. Okay. We haven't delved into the fix and replace geriatric type things. But again, the principles are that I would achieve fixation such that a patient could weight bear as tolerated. And if you thought your fixation was feeble or through osteoporotic bone, there's damaged femoral head, osteoporotic dome impaction, then those are classic indications for urgent total hip replacement surgery. So that's the acetabular fixation or acetabular classification. Predominantly, almost all displaced acetabular fractures require operative fixation. So you go, what is stable and unstable? Like, well, it is displaced, and acetabular fractures do not tolerate this displacement very well at all. So the only things we don't operate on are undisplaced fractures, and even occasionally on those ones, we'll percutaneously fix them with potentially anterior column screws or posterior column screws to prevent any migration. That is debatable. Whether if they're undisplaced, they probably don't move at all anyways. But if they do, then you've missed the boat. Good. So take-home message is, if it's displaced and fractured, requires fixation. If there's medialization of the femoral head, that requires a intrapelvis. Some people have rebranded the stopper approach to anterior intrapelvis, but you can just say that if there's medialization of a femoral head, then that would require an intrapelvis fixation. And then if the posterior wall is involved, or any particularly posteriorly, that require a Cocker-Langenbeck type approach, and then leave it at that. So I'm just gonna get sure. Yeah, we'll just carry on. I was wondering if we're gonna have a break for 2 minutes, but let's just carry on. Or any questions? We're now gonna go on to pelvis ring injuries. I can't hear you. You're on mute.
Sorry, my apologies. That's terrific. I was just one quick question, if you don't mind me asking.
Yeah.
Often with the quadrilateral plate fractures, from my experience, we always put a pin in to pull the femur out. Would that be a worthwhile point to make in the exam, demonstrating that you've seen these approaches and surgeries?
So yeah, so how to achieve traction intraoperatively? So that can be with so I'll just go back. Let's go back. So here, so how to traction will help. So these will just fold back in rather than during the intrapelvis, which is fighting up against the vessels. So sometimes even just if there's a small amount, an assistant pulling on the leg, a third or assistant, fourth assistant. But what a nice trick, which you've done, is to put a Schanz pin up just like the track of a DHS, or even into this stronger calcar bone, stop it about here, attach it to a T-handle chuck, and then lateralize it. We have actually written a paper, a few papers I've written, which is on the Star Frame website, due to be published, but it's a white paper at the moment, where the problem is if you just pull on it, then you can just pull the whole hemipelvis. And so the Star Frame, STARR, out of Dallas, it's just the half of it is a carbon fiber rods attached to the table, to which you can attach a ball spike pusher to act as counter traction. So you have a pin here attached counter traction, and here your Schanz pin attached to what is essentially an AO driver, and then you can wind it out. And then once this you achieve, like a hip arthroscopy, once you achieve 2 or 3 or 2 centimeters, 1 centimeter of distraction, then these fragments can fold back into place much easier.
Thank you.
So,
and in the exam, a couple of previous candidates have said that they were asked, "What do you do with the evidence of a Morel-Lavelle lesion associated with an acetabular fracture, a degloving injury?"
Yeah. So the Morel-Lavelle injury is you have a shearing forces of the fatty layer against that your fascia lata. Typically it can be a part of that glute max, but typically your fascia lata, and then that, which actually you do a total hip replacement and you get your Bristow and you push it, you're creating a mini little Morella-Valley iatrogenic injury yourself. So I mean, we do get away with it quite a lot, but you can get huge amounts of edema, and actually there's not whenever there's 7 different treatment methods, it means none of them work terribly well. You can just ignore it and eventually it can go away. There can be a huge seroma. You can try to aspirate it. Some people have talked about putting a sclerosing agent, whether that's some sort of erythromycin type powder or talc type powders. So as plastic surgeons will try to weave stitch it back on. It's a large seroma type thing. So that's your Morella-Valley lesion. Would that stop you from operating? Probably not. Because
would you put a drain in that scenario after you finished? Would that help with the seroma, or would you wait until the seroma develops and then?
Yeah, we don't, like, probably like all orthopedic, we don't routinely use drains, I suppose. And then like this trends, we like, we'll use a Pico type dressing, but there's no evidence for that after our WIS trial. So yes.
Also, a couple of more questions. Sorry, if there is polytrauma, people are very interested in this topic. If there is polytrauma needing laparotomy, for example, by general surgeons, do you fix the acetabular fracture at the same time, or do you wait until a later date?
So pelvis ring fractures often need stabilization, whether that's temporary with a pelvis X-fix, which is unusual, or the binder. That's the pelvis stability is more important for their entire stress scores, as it were. But the acetabular surgery can wait, often waiting that 7 to 14 days. The only caveat to that is if there's a fragment. So they would have, so certainly that'd be the time to put a distal femur traction pin, and then they can have that they can have the skeletal traction. It's more effective with that sort of 5+ kilograms. And these days we don't seem to have weights, it's just saline bags. So you're looking at 5 saline bags or 2 3-liter bags. Yeah, I mean, so the only caveat to that would be is if there's an incarcerated fractured fragment of the posterior wall that's stuck inside the joint. And then we have one of the tips and tricks is you can try to fish that out percutaneously by really, you can get a long artery clip and fish it out and just stick it somewhere, knowing that, you know, when he's better, a week, 7 days down the line, when you do your posterior wall, or if it's there. So you don't want it, sometimes, you know, it's the size of a dice crunching around inside the joint. And you don't really want that there for 7 to 10 days. So you can just fish it out, but that's very unusual.
And now we're moving a little bit away from the FRCS level questions, but if you could give a quick one-line answer would be great. Asking about suitable time for doing an acetabular fracture surgery. Do you prefer to do early fixation or late while maintaining traction, as you were describing for the open laparotomy type patients? And
yeah, so you know, when the patient's fit. So if you really want to go on there, lactate, but if it's it's not absolute, like I suppose like a Schatzker 6, but actually our soft tissue enveloping window is not as fragile as a proximal tibia, for example. So and this, I think we all let it settle down. No, I mean, a posterior wall acetabular fracture, isolated injury, you could fix that within a day or so. I think there's nothing to say you have to wait, but obviously when in polytrauma situations you can wait, that's fine.
Okay. And combine, again, this is outside, but just a simple answer. Combined acetabulum and pelvic fracture, which one to be tackled first surgically? How would you approach? Which?
Yes, so
Oh,
pelvis ring.
thank you.
Just your pelvis ring is more important. And then sometimes you can't reduce a fracture of your acetabular fracture because your whole sacroiliac joint is disrupted, and that is your constant fragment. So we typically say you have to build from the back forwards. Would be the crux of it. Pelvis ring. So pelvis ring instability is more serious. Can be life-threatening. There are very few orthopedic injuries that you die from. I suppose if you hit the femoral artery from a femoral femur fracture, but we almost never seen that. But the exsanguinating pelvis can be a major life-threatening injury. Actually, with the advent of pre-resuscitation care, we're much better. Interesting, when you go to some of the North American conferences, they still have pretty poor pre-hospital care compared to actually our NHS. So they don't always have binders. They don't have blood on scene. They don't have the HEMS type doctors. Well, there's generalization for all of America. And so in America, they're still going on and on about these, should they go to angio or should they be pelvis packing? And actually, they're probably just under resuscitated. And once you've missed that golden hour of poorly resuscitated, then you can go into a coagulopathy, and then you're constantly chasing and you never catch up again. So can have very high mortality when you're uncontrolled bleeding. And actually now, if we're getting that binder on very quickly, we're creating a clot, we're getting our coagulopathy under control. Actually, the death from an exsanguinating pelvis is very few and far between. So, and again, when we think about the imaging that we get, again, there's sort of pelvis binder straight through onto into a CT scanner. But your normal X-ray things, your normal to look at is again an obliquogram. And so we actually want to see is the inlet view where you're looking down into the pelvis, and an outlet view where you're looking at essentially an AP of the sacrum. And so it's here where you can see if there's displacement. And if it's just displacement on its own, you're like, well, that's not a big deal. But you can look at a picture. Can we hear all the vessels here of your sacral plexus, both the venous plexus and the arterial plexus can be hemorrhaging. There's a superior gluteal, all of the branches of the internal iliac. And you're like, oh, go to angio, go to angio. Well, angio can only deal with the arterial bleeding, which is actually pulsating and dramatic, but you can still have lots of venous sacral plexus bleeding, which you can't treat with an angiogram. And so that needs some sort of pressure to essentially, and whether that pressure comes from pelvis packing or whether that pressure is actually often from the binders. Think, oh, what are the binders are doing? And just like you imagine, if something's bleeding, your first reaction is to press on it. And that's essentially what the binder's doing. So nothing to do with the fracture configuration. We'll talk about binders a bit more, but people are, can we take the binder off? Is it okay to ask the orthopedic surgeon to take the binder off? Like, there's nothing to do with it. It's just that it's a hemodynamic stabilizer. And if this patient is hemodynamically stable for a good period of time, call that 12 hours, 24 hours, then the binder can come off. People can have an open book pelvis. They're hemodynamically stable. They can sit on the ward for 5 days plus waiting for their surgery. You don't need that binder on. The binder is a hemodynamic stabilizer. And so that's the resuscitation team, the ITU team, who can make that call that it's safe to come off. And and it needs to come off within that first 24 hours because it can cause pressure ulcers. And then very occasionally the binder, you take the very next day, typically we take it off the next day, you go to take the binder off and then the patient can crash or the blood pressure could drop and go like, oh, so we slowly take it off, see the blood pressure still okay, if they've got a big bleed or clot. But if they start to drop the blood pressure, then you can do it back up again. But you can't just leave it at that because you can't leave these binders on for one, we've seen big pressure sores, and that is the occasional once every year or 2 years where they will need an external fixator. So they're too unwell to have a large ORF type thing of their pelvis, but they can't have the binder on for too long. So then they do need, and that's just, you know, pins into the iliac crest, into the iliac crest, or the supraacetabular. And so then your external, the X-fix, they're all pelvis X-fix. We really do put these on very rarely these days because the binder has done the work. So the common working classification system that we use, again over the phone, is this Young Burgess classification. And so, yeah, again, you don't have to get bogged down with this. I remember at my FRCS, I was like, oh, so if it's being compressed from the lateral side, and then I see a left pubic rami fracture, but then it's from the right, and I don't really get it. And that's because just ignore the pubic rami fractures. And again, just try to describe what you see. But when as pelvis and referring centers talking to you, they're like, oh, that's a stable LC1, and that's an unstable LC2, and so we kind of know what that talks about that, and I'll go through this in a bit more detail. And you have to remember that this is really important. The Young Burgess classification was actually probably just invented in the pub on the back of napkins, going, okay, we've got all these unstable pelvises, let's try to put them into 4 or 5 groups, and then when we do make our databases, we can help work it out. But actually, there's lots and lots of overlap, and most of them require operative fixation, and so this combined mechanism can make up 40–50% of injuries. So if you are getting bogged down, you go, oh well, this is probably a combined mechanism, and almost all of these injuries are unstable. You're trying to, what is stable, what is unstable? And so unstable requires operative fixation. And the only thing that doesn't require operative fixation is this lateral compression. I'll talk about a bit more detail, is classified into 2 parts, a stable and an unstable LC1. And the stable LC1s is the highest volume. I get referred every day, twice, like 200 stable LC1s. Actually, it's probably just pubic rami fractures, but now everyone's getting a CT scan. We see a pubic rami fracture and a buccal fracture, almost like a torus fracture of the sacrum, and that's stable. It's only when it's a complete sacrum fracture we call that unstable. Now, what's a complete sacrum fracture and what's a vertical shear? No one knows. There's no. It's almost one and the same, but the vertical shear is sheared up a bit, but still, it's unstable. So, stable lateral compressions, unstable lateral compression type 1. And then everything else is unstable. Let's move on. So here we are. Here's our LC1 fractures. Now, a really important mistake is that, oh, it's a bad LC1. Therefore, it must be an LC2, like all orthopedics. 1 is okay, 2 is worse. No, it's like an LC2 fracture is the ilium, this bone here. An LC1 fracture here is this buccal of the sacrum. So it's 2 completely different bones. It's like saying a radius fracture and an ulnar fracture, that they're just 2 different bones. So an LC2 fracture has nothing to do with an LC1 fracture. Okay, so this fracture here. This is our stable LC1s. We're often and the sacrum and the sacroiliac joint complex make up 90% of the stability of the pelvis. So just ignore the pubic rami fractures. We always want to look at the back here. So at the back, and so I see this fracture line, and then I'll scroll through with the mouse, and I'll see if this line extends, and it's obvious it doesn't. They'll buckle here, and I'll have that pubic rami fracture. And these patients can weight bear is tolerated. I don't follow them up. In reality, it means that although we say weight bear is tolerated, they're probably going to be a bit of pain here on this left side. So you say you'll probably have to have some crutches for about 4 weeks, which will be full weight bearing on the right and partial on the left until the pain settles. And then we don't quite. Some people are absolutely fine, and some people really do need those crutches for 4 weeks. Interestingly, I see some people come across from Europe for some injuries, and they've been told to total bed rest for 4 weeks, and they come back 3 weeks later, and I just push on the heels and get them walking. They're like, "Oh wow, you fixed me," but I didn't do anything. So it's just the evolution of our weight bearing status, and that's still evolving. We still don't have any good imaging of weight bearing and how stable or unstable fractures are in weight bearing. It's still a big conundrum. Moving on, so these LC2 fractures, this so you can have a fracture of this ilium, which I'm just going to move this box here, and so it's a fracture dislocation. This gets into the sacroiliac joint, and sometimes if this fracture dislocation can be fixed percutaneous with an iliosacral screw, because the fracture is posterior enough such that the screw would be here again to our constant fragment. Or whether, just along these lines, whether you can actually fix the percutaneous screw from frontally back. And old school, you actually used to do a posterior approach, put a little plate across that. So that's LC2. And then LC3 is actually just both sides. Both sides of the sacrum and the sacroiliac joint are fractured. So there's LC1, 2, and 3. And so, and then over the phone, you're like, oh, actually, it's an LC1 on one side and it's LC2 on the other side. They do kind of add up, actually, LC3. Or you can have just both sacroiliac joints gone, that's an LC3. Any very bad disruption is an LC3. Again, it just means they all need fixing. So, but it helps us understand it over the end of the phone. And again, this is why it's so important, is that, you know, the forces that go through a pelvis to fracture it. So, you know, we concentrate on the bone, but there's a lot of other shit going on, sometimes literally, so that those fragments of bone can penetrate the rectum. And that's why we say that the rectal and PV examination is critical. And a missed perineal rectal injury can have devastating injuries. I've seen entire scrotum skin die over the course of days, and patients can die if they have fecal contamination of this polytraumatized area. So that's why these patients need a fairly urgent defunctioning colostomy, and usually external fixator initially to sort of just stabilize it there or thereabouts. And so these are things you're not want to miss. So why their pelvis fracture is one of multiple sort of abdominal type injuries. Sometimes those fragments of bone can puncture into the bladder, sometimes they can puncture into the vagina. Again, we've gotten caught out with big chlamydia, actually, for the bone fragments in that. Sometimes the bone fragments have penetrated into bowel and causing devastating injuries. So one of the keys is, you don't focus on the bone, focus on the soft tissues. But lots of orthopedic surgery, we always get caught out when we ignore the soft tissues. This anterior APC, anterior posterior compression type injuries, pop pelvis, basically. This symphysis is fairly binary. It's either popped or not popped. Some people, the classification system really talked about whether you can have a minor disruption. That doesn't actually exist. And in their series, it doesn't exist. So you're right, you call it a sprain if you're symphysis. That's basically full weight bearing, so it doesn't change your management. And APC2, so that's the most common. So it's a pop symphysis, a little bit of disruption of your sacral ligaments at the front, but the sacral ligaments at the back are intact. APC3 injuries, that's when your whole sacroiliac joint is disrupted, and that has prognostic indicators. And you less likely have to do a lateral window and open approach, or anterior approach to reduce and clamp that sacroiliac joint and plate that. And then this image on the right, you're like, well, but isn't that vertical shear? You're right, it is. And so, a room full of pelvis surgeons, half of them would say this is a vertical shear injury because this whole hemipelvis is migrated, and half might say that's an APC type 3. Again, it's irrelevant. The treatment is to reduce it, plate it, and fix it. And this injury, you can see this entire left hemipelvis can cause major disruptions to the arteries, the veins, the lumbosacral plexus. So I've seen complete lumbosacral plexus injuries, like a brachial plexus injury, except unlike a brachial plexus injury, there's no treatment. So they are basically paralyzed on that leg. Here we see this vertical shear injury, and so the fractures of the sacrum. Also, there's even a classification for that, a Denis type classification, whether it's 1, 2 through the foramen or 3 medial to the foramen. And again, that has sort of prognostic in. If you've got a fracture through the foramen, the chances of your sacral nerves being damaged is quite high. Just like here, we see this here. You can imagine the nerves popping out through here, they're all going to be damaged. And whether this is associated popped. That's just a post-op CT scan, very, very close anteriorly. Whether it's fully threaded or partially is not for your concern, but that's the sort of fixation we can achieve. Somebody can talk about resuscitative screws. So you can just put a screw across, really to clamp it down to get some sort of compression. Can you put in a quick iliosacral screw? Because you can, if you had a huge, 5 centimeter diastasis here, and that's where it's all bleeding, you just need to compress it down. Again, high level stuff. So I've got a case example to go to finish off with, but the take-home messages from your pelvis ring injuries is that they hemodynamic stable, your ATLS principles, obviously. Hemodynamically unstable patients are not responsive to their initial resuscitation. Can be treated with discussed with interventional radiology if they see a suitable, and they're much quicker at it now. I think in the old days you're like, oh, we go off the angio, it's going to take 2 hours, and then they'll die by the time they get there. But actually they're really quick and good, and so they can get in there and they can treat that. Or they get rushed straight up to theater and they have a laparotomy, and you can do packing. And they can have both. They could have a laparotomy. They could see that, because often on their CT scan, they can see that bleeding. They're like, I know I'll get that. They can get it. They can stop that bleeding. And then they have then they might have a laparotomy for something else. I need some pelvis packing against. You have the pelvis pack against something stable. You can imagine if we go back, if you just pack up against here, it's all going to bleed. You're packing against something unstable. So you need to quickly put on your iliac crest pins and pack against something that's stable. Again, where do you pack? I don't know. And it's in that stopper approach, which is that space of rictus. And you're like, oh, there are these 3 little swabs just in the right place. In reality, you're stuffing as many large packs into that area as you can, and you're getting this massive pack, and that's creating some compression and some sort of hemostasis. And you could pack it, and then you're still bleeding, and then they go off to IR. So in my mind, I'm thinking that the packing is dealing with the venous bleeding, and the interventional radiology is specifically seeing it as isolated now. They used to do quite large internal iliac, but they can be very specific. They can see that superior gluteal. That's the bleeding. I know I can get that. I can get there within 20 minutes whilst he's being resuscitated. These are the sort of conversations. And at this your FRCS level, you say, this might be suitable from my end. This might be suitable for interventional radiology, or this might need to go emergency to theater, depending on how the resuscitation, and that's to do with their blood volumes and things. Ready to be able to stabilize that fracture to allow with my trauma general surgeons. Okay, onto a case study, and I'll take some questions and do some bias. So I was a consultant. I was still a local consultant within my first year. This guy came in. You can't quite see it, but he weighed 220 kilos, and he was doing some wheelies, and he ran into a van, and then the petrol tank blew up. So he had 3rd-degree burns. He was in shock. They couldn't get the urinary catheter in. They had to find his urethral meatus. They could hardly get him into theaters. He didn't fit in the CT scanner. They took some x-rays. This was the picture of his bike, which was all burnt. This was the poor van that he hit, weighing 220 kilograms. This is the x-rays taken that, so you can see he didn't fit. So this was one x-ray, this was the other x-ray, and you have to piece them together. And still going, what on earth is going on? And then the sort of the keen eyes in there, you see that actually this bit of the sacrum belongs to this bit of the spine. So this huge diastasis here, and this huge, so this is a vertical shear combined injury. And you can imagine this blood just pouring from here. Binder it was absolutely enormous. But he was just about holding in there, but for the first 24 hours. But we did have to do, he wasn't stable. And we did do fairly urgent surgery the following day to reduce that with ball spike pushers, pushing against that side. He had 40, can you imagine normal people, if you can feel your greater trochanter, You can push on that. That's 1 or 2 centimeters, or gluteal. When I do my percutaneous screws, this guy had 30 centimeters of adipose tissue before I even got to the bone. So then my guide wire, which was then all the way here, I couldn't grab it. So I had to make a 15 centimeter incision, about the size of a hip replacement, to then put the drill bit all the way into basically what's his buttock, to then get the screw there, to then fire it across. And you can see with the adipose tissue, so this was up to it, up there, thereabouts, and this was the diastasis. And I was just about hoping that the power of the screw, and luckily he had actually very, very strong bone. He was only 26 years old, and that bone was being wolf's law, becoming very, very strong to accommodate for the 220 kilograms. So actually it's very strong bone that the screws actually did the work, and the threads and the partial compression compressed it down. He was the one, he had a permanent lumbosacral plexus palsy and never recovered. And he eventually did go to the CT scanner. It was actually near the Olympic Stadium. They have to have a bariatric CT scanner to hold the Olympics. We tried calling the zoo, because your standard CT scanner won't take this patient. And this is a scout view film of them. And then, so, these are 116 centimeter screws and this tiny little pelvis stuck inside this huge patient. And it turns out if you're 26 years old and paralyzed and 220 kilograms, you basically kind of need to go to a nursing home, but there's no such thing as a nursing home for young people. He spent 390 days waiting for his young adult nursing home placement. There you go. I still didn't quite get the full reduction there. He also had this really unusual scapular fracture for you upper limb surgeons there. Okay, so that's me done. Questions, and then we'll do a couple of vivas.
Well, I can definitely, I'm sure I'm speaking for everybody, that was quite impressive. But also, that was an amazing talk. Thank you very much, Mr. Paul Harnett. I do have a comment / question from myself, if you don't mind. In the exam is all about safety as a DGH, year 1 DGH consultant. And when you're asked where you're going to go with a patient who's not hemodynamically responsive, I've always thought the safest answer is to say, I'll take him to theatre because we can get embolization and angiogram on the operating table, as well as have surgeons ready to go if we fail to, or if we can't get it quick enough.
Yeah, so
depending on radiology being on the ball.
So really, you're talking about that's really a hybrid theatre, which doesn't. There's only one place in the UK. So you'd have a combined resuscitative theatre with interventional radiology, and basically the interventional radiologists don't play outside their own. They don't go. It can be done in some places where they'll use just a pelvis table and kind of get away with a C-arm, but no, they have these crazy special C-arms and all their toys and all their kit, and everything is all lovely set up, often quite close to resus, and the patients will go there to the interventional radiology suite. It's almost like saying, in fact, just think about it now, it's like asking your surgeon to not operate in theaters. So can your surgeon put a pelvis X-fix on in resus? You're like, well, I suppose I could, but I don't really want to and don't like to, and it's not safe, so I'm not going to do it. So we've never put a pelvis X-fix on in resus. And equally, so at the moment they are still separated, and certainly in the DGH they would be separated. But ultimately you'd think, why don't we have a hybrid theatre where you could do everything in one place?
Yeah. So if this came up to you, you're in the DGH center as opposed to the trauma center, or even if you're in the trauma center and you've got
do DGHs have interventional radiology?
I don't, not all of them.
So hopefully this patient, we could say, well, hope this patient with a new gut should never have arrived. You shouldn't have an unstable polytraumatized pelvis ring instability arrive at the district general hospital. But should they, then my principles are to stabilize with a pelvis binder and ensure adequate resuscitation with blood and tranexamic, we didn't talk about tranexamic acid, and that they could then be transferred to their specialist unit whilst they're having the resuscitative blood, which they can have, and the pelvis binder, and that will have to suffice. Because actually, if they go to theatre, you put it next. Yeah, no, I think places where they have interventional radiology and trauma patients with trauma laparotomies and or pelvis packing, that would be a safer place.
Perfect, thank you.
I can see some of these comments here. Any role of using Jude views at all, or we just rely on CT? Yeah, just CT, and then you can do simulated Jude views.
I think, but there's also the argument that if you, sorry, I'm not disagreeing with you, but at the 6-week mark, when you're doing a check X-ray, you'll use Jude views. The role, there's no role for Jude views. So I think that was the question.
Here we go. So I didn't understand the management and concomitant morale value. There is a very high risk of infection there. No, I think no, that wouldn't. The risk. There will always be some sort of well, if there is some, that's not a contraindication. The risk of infections are not drastically higher. You'd cut through that. You can treat if you are doing, say, a Cocker-Langenbeck approach. That's typically where you might see that morale value, and you would wash and take that, because the risks of non-operative surgery are, post-traumatic arthritis and severe, and your Morella Lavalley lesion is not going to, unlike, say, a Schatzker 6, where the soft tissues might settle down, the skin might settle down over 7 to 10 days, your Morella Lavalley lesion is never going to settle down. So you kind of just have to bite the bullet. And are the risks very high? No, they're just a little bit, from 1% to 5%. And again, we probably would treat that with the weaving stitch through the fatty layer, just like we do a fat stitch, but then you can combine that into the fascia. Is sacroiliac screw positional or lag screw? Yeah, so we try to achieve the reduction. About half the time it's fixed in situ, but sometimes we try to retrieve the reduction with a ball spike pusher and pushing, but sometimes at the partially threaded screw and the washer, the few turns will actually close down the displacement. So that's a pretty technical question. Sometimes people will do an open approach to the sacroiliac joint to clamp it, to clean out the gunk inside the sacroiliac, because all those ligaments being torn and washed out. Some people will do a posterior approach to the sacroiliac joint to clamp it and then reduce it, and so then the screw is yeah, it can help reduce it, but often it's like lots of things in orthopedics, you can't rely on your hardware to do the reduction, but sometimes you can. Okay.
If there's no more questions, I want to thank Mr. Paul Harnett again for an amazing talk. Acetabulum and pelvic injuries are complex and difficult often to understand, but you've made it very simple and straightforward, and a much more concise way of preparing for the exam than a lot of the textbooks.
Okay.